Uganda ratified the Social Development Goals Strategy Agenda crafted by United Nations member states globally in order to make improvements in the livelihoods of its citizens. Among the 17 goals, goal number 3 seeks to ensure good health and well-being among the population. This majorly involves a phenomenon termed as universal health coverage for all, and basically refers to the ability of all people who need health services to receive them without incurring financial hardship. Universal health coverage comprises 4 tenets, which include managing the burdening of financial health care, increasing needed services of good quality, expanding the populations reached by services, and building systems to support quality services. But what steps has Uganda put forward towards achieving this goal?
Health is very important because it will enable you to do what you want to do in your life. Therefore, when I hear that we can have an AIDS-free society by 2030, I feel very happy. On the issue of mother-to-child transmission, that one has already been, a lot of achievement has been done. There are still these 4,000 people. Are they 3,000? The ones who are still being born with. But we should also close that, go to zero. Why 3,000?
From the 80s when the situation was really grave and terminal, now we are more worried about people getting the medicines and swallowing them. In immunization also we've made tremendous progress. Diseases like measles and others that used to kill a lot of our children have really reduced markedly. So there is some progress in some areas.
Uganda's current health interventions only focus much on treatment services as compared to reducing the disease burden.
And it's well known Uganda is still having very many preventable conditions or illnesses. So I think this focus of the Sustainable Development Goals is to try and focus governments into all areas that create well-being and improving health.
But it is also evident that the burden to address these health issues can be shared in various ways.
Investment in other areas, for example water, can bring us a lot of health benefits and can keep many people healthy. Investing in road safety recently has demonstrated that putting money into police, into safe road, and making sure that the court system punish those that are overspeeding has brought mortality rate or death on Masaka, Kampala Road markedly. So you don't have to put money into health directly to benefit Ugandans. And that is another aspect that the new Sustainable Development Goals are asking us to look at.
So that means that we need to have the infrastructure improved such that the people don't have to move long distances to access the services that they need. And here the services, the infrastructure we are talking about is not only the health facilities, but also the means of reaching these facilities, and also looking at the prevention and promotive health services.
However, healthcare financing in Uganda is inequitable and fragmented.
I think as a country, when it comes to equitable access to healthcare or fairness in terms of how health resources are distributed, we have a lot of room to catch up. Right now, when you look at, for example, the health workers that are professional, doctors, nurses, and the surgeons, you'll find most of those are in urban centers. When you go, the further you go down to reach remote communities, you find nursing assistants, 1 or 2 nurses, really managing the entire health facility on themselves, and sometimes overwhelmed, they can't provide all the services as required at those levels. So how do we balance and try to make sure that services at that level also get quality, people can work there comfortably, and government can direct some of the resources to uplift these areas which require more attention.
We have done many things. Now we need to move beyond just looking at resource mobilization
an allocation formula. You know, this is where we are still stuck. When you look at Uganda's now actual operations, implementation when it comes to finance, we stop exactly there. The best we have done is try to come up with a formula for allocating PHC grant at the district, and which represents less than 20% of the entire health budget. So we definitely need to move beyond that.
Financial protection is generally low, requiring most patients to pay for health services from their own household income.
Nowadays, the charges are very high. As it is a government hospital, they charge little by little because it is a government hospital. But you buy, as when you buy it, you have not. It is too much.
The struggles involved in getting access to affordable, quality health care are a daily story told by many in Uganda.
The moment we got here, we were told very politely that we've got to pay for everything. And that's what we did, from the cannula to the giving set, to the needles, to the medication. And it's a bit of a constraint. And then you're sent off to the shops. Another constraint that we have as people who have to procure medical services is the fact that there's a whole array of medical drugs, some that hardly work. So you've got to choose between the same drug at 5,000 and at 18,000. We're not sure which drug you're buying is the right drug. Is it German? Is it Egyptian? Is it Indian? Is it Chinese? And you have to keep on juggling your chances to see whether the drug that you have procured will work well with the patient you're treating. It's a problem. When we got here, the power went off, and I was shocked that for 40 minutes, the generator wasn't working. And you can imagine, even if you have paid, and you're in the theater, you're in the labor ward, you're in intensive care. I understand so many people had to be referred. I just came short of asking, what about those that they had opened up in the theater? So sometimes it's not a guarantee that even if you've paid, that you're going to get the right treatment.
Before, retention of staffs was hard because most of the manpower was from outside the district. And given that time that we had a lot of insecurity, we could recruit the staffs, but maintaining them here, they could just disappear, go away because of insecurity.
The effects of such struggles also impact the relations between patient and service provider as well.
Definitely, you are affected when you see such a patient. You take it, maybe it is your mother, supposing it was your mother who is not able to see a doctor because she doesn't have money. You are affected.
The country's health budget is 1.8 trillion for financial year 2017-2018, which is only 7% of the budget instead of 15% as agreed by African leaders at the 2001 Abuja African Union Summit. In addition to developing such strategic documents, the government of Uganda, through the Ministry of Health, has embarked on several processes aimed at ensuring effective implementation of universal health coverage.
Because universal coverage does not come on its own. To achieve coverage, you need to build the health system capacity, its financing, and its availability. So right now what is being done is a deliberate policy, and it becomes a measurable and accountable outcome that people are all covered, so that it is just not implied, but purposely pursued. And so it is there in the current development plan. And since health programs like mine of malaria are guided by the overall ministry's development plan, we now have to operationalize it by ensuring that our interventions also are going to scale. So what is really happening is bringing emphasis to operationalize a goal.
The health service delivery system in Uganda is decentralized, with districts and sub-districts playing a key role in the provision of health care. One of the aims of the decentralization policy in Uganda is to enhance the efficiency of resource allocation for the achievement of development goals in line with local priorities.
But their performance depends on the support from the center, because the center still has to make the correct policies, do quality assurance, make resources available.
While local governments receive funds from the center for healthcare financing, local government health managers and leaders are often involved in mobilization of additional resources for their constituencies.
Like for us now here, we have a number of partners who give aid to the health facilities. We are the one partner called UNFPA. It's UNFPA. It also gives capacity building to the midwives. And also UNICEF gives support in terms of hygiene and sanitation. That is establishing the latrines in the health facilities and also providing water for the facilities.
Makerere University School of Public Health is currently running a 5-year European-funded project, SPEED, whose goal is to strengthen capacity for policy analysis, advice and influence at Makerere University School of Public Health and contribute to accelerating progress towards universal health coverage and health systems resilience in Uganda. Started in 2015, SPEED has created spaces for the discussion of universal health coverage issues, especially the policy arrangements that are a requisite for its effective implementation.